Moving on to our next session by Dr. Biju Potakkat sir on diet in patients on tube feeding with renal failure. I request the chairpersons, Dr. Suresh Babu sir, Senior Consultant Nephrologist, Yashoda Hospital, Secunderabad. Dr. Kiran Kumar M, Senior Consultant Nephrologist, KIMS Hospital, Kondapur. And Dr. Ashwini Dutt sir, Senior Consultant Nephrologist, KIMS Hospital, Minister Road, Hyderabad.
Good morning, everyone. In continuation, we are moving towards a very special scenario where the CKD patients cannot eat through the mouth. So the patient worries, family worried, natural nephrologist worries. So in such a scenario, we have to speak on about that. We have a very expert, Dr. Biju Potakkat. He is a professor and head of the surgical gastroenterology.
It's okay, fine, yeah.
JIPMA.
It's okay, fine. And thank you very much for inviting me. So these patients, the protein energy wasting, which is the most important nomenclature we have to understand. And more and more we are understanding that this problem is increasing. And transplantation is a strategy in the nutritional front also. So transplant reverses this nutritional problems. When do you think about a tube feeding? So when oral feeding fails or meet targets, it can also be a bridge to oral nutrition. That essentially means that you can keep a tube feeding as a supplementary nutrition as well as a obligatory nutrition. There are some intestinal or gastric issues which are related to kidney failure or any other significant diseases. They can have antral obstruction, paralytic ileus, and the emergency nature of the disease. So the feeding comes down significantly. That time we can think of tube feeding as well. And this vomiting, diarrhea, gastroparesis, and administration of semi-digested diet-induced complications also, you can think of tube feeding. So delayed gastric emptying is a problem in CKD. It's a less diagnosed entity. Some of the patients definitely suffers from diabetes. They'll have autonomous disturbances, and this also aggravates the CKD. So we have parenteral nutrition in hand, but why are we not using it? Parenteral nutrition is a semi-controlled food delivery system. It directly goes to the bloodstream. It can also cause a totally unrelated complication which is called infection. And the metabolic disturbances, especially in kidney disease patients, are sometimes lethal or problematic. So this group of patients, PN is much more reserved. So what happens in CKD patients if you don't feed them nothing through mouth? So there will be morphological changes in the gut mucosa. So the thickness, villus height, all this comes down. We have to remember that the gut is the best food filter available as of today. Nothing can replace it. So if you don't feed, the intestine will also suffer from this protein energy wasting, apart from the mucosal problem. So when you prevent metabolic disturbances by modifying absorption, the gut is the best option. That's why we prefer gut as the route for nutrition, grossly overriding the impact of parenteral nutrition. And more importantly, as I said earlier, the high prevalence of diabetes, the insulin homeostasis and glucose homeostasis, the enteral nutrition is much better. And it is less costly. And another important area is as you keep on giving parenteral nutrition, your vascular access keeps on disappearing. So this is going to be troublesome, especially in patients on dialysis. So the four methods of food delivery to the intestine, these are nasogastric tube, nasojejunal tubes, percutaneous gastrostomy tube, feeding jejunostomy tubes. So as you know very well, in the kidney disease literature, there is a high information or high amount of data for PEG tubes. But PEG tubes, we have to remember that it has more complications than the other methods. Okay. It is long term, but more complications. So nasogastric tube, we think of short term. Short term essentially means we look at 2 to 3 weeks. Nasojejunal tubes, we look at 6 to 8 weeks or 10 weeks. Beyond that, it is better to have a gastrostomy tube. So when you have a tube in situ, please remember that it is going through nostril. It has its own complications, and it's a major restriction to the normal living of the individual. It has other complications as well. It significantly affects the quality of life. And there are several reported and reportable events and never events as well related to tube usage, and some of them can be really lethal. So very short time, if you want to use feeding tubes, be careful. So, but it is safe despite the incidence of complications. So now once the tube is in place or select your tube, we have to select the delivery method. So pumps, gravity feeds, bolus feeds, and this can also be individually tailored as well as used in combination. One day you can use the pump, next day you can use the pushing methods. So when you start tube feeding CKD, if they are unable to eat the daily requirement for a long time, and there is severe anorexia and there is sick patient. The sick patient is a vague term, but we can use it very scientifically on bedside, on frequently, on various occasions. And the subgroup of patients with the hepatorenal syndrome, this tube feeding is indicated. But in children, in the previous talk elaborated extensively that tube feeding is much more important in small kids with CKD. There is a strong recommendation, but the most important component is deterioration in weight. This is applicable to adults also. So we had reservations in putting tubes during the peritoneal dialysis catheter insertion, but now more or less we try to put it. We have to remember that this both the PD catheter insertion as well as the PEG insertion, all this can be done in a minimally invasive way nowadays. Very small incisions, you can put multiple tubes. The advantage, you are not disturbing the peritoneum. So the further advantage you will realize when you get these patients for re-explorations. So orals can be continued along with tube feeding. So it is not a all or none phenomenon. All mix-up can be done. Please remember about diarrhea because your gut may not function very well in CKD patients. So when you administer tube feed, please remember the exact status of electrolyte we need to know. Otherwise, you will be pushing unwanted elements which can have metabolic disturbances. And a good proportion of patients with CKD tolerate standard diet. So we have the habit of modifying the diet once the disease is identified, once the product is available in the market. It's not that all CKD patients need a modified diet for kidney patients. It's exactly same as liver also. Some of the factors we need to consider, dilution water may change the concentration of the electrolytes. This is going to the gut. So gut absorption also depends upon the, not the absolute value as well as the concentration. So your fluid administration may change the concentration, and drug administration also to be carefully timed along with the feed. And in small kids, the flushing volume can be significant because if you don't flush to 20 to 30 ml, the tubes will not work and it gets blocked and cause additional problems. So we have the habit of recommending everything 24 hours, but 24 hours is not the day for a patient or an individual. Sometimes we have to tailor our 24-hour recommendation for administrative convenience to 16 to 18 hours. So the extra requirement has to be added. And sometimes 24-hour calculation is not at all workable in some group of patients. There may be investigation, there may be dialysis going on. So sometimes in bedside, we look for a 2-day target or 3-day target. This is also a practical useful tip on the bedside, especially in patients for tube feed. So you may have long intervals of 12 to 14 hours of no feed at all. And the rate of delivery is also important. In elderly patients with CKD, so this is a separate group altogether. So when you have old age, there will be significant muscle wasting. So sarcopenia, despite multiple definitions available, we need to remember that the muscle quality is also getting lost. So the direct effect is they will not be moving as required. It accelerates further disuse atrophy, more catabolism. So when you have acute kidney failure or other acute illness, these patients have lot of morbidity issues in the ICU. So intense proteolysis happens, amino acid conversion happens from the stored protein, and this will cause further injury to the kidney and liver. So prolonged acute kidney injury in ICU is also a nutritional problem. The innate immunity is lost. The patient is on less defense systems. Your protein transporters for drugs are severely affected, and there will be a significant shift in the fluid balance intravascular to extravascular. So this will also affect your nutritional delivery, administration and nutritional recommendations. In hepatorenal syndrome, which is a separate entity highly related to two vital organs, some important changes are required. So both organs may affect the protein, carbohydrate and lipid metabolism, and additional electrolytes and fluid disturbance due to kidney failure. So nutritional losses and gain from dialysis can also happen. We also need to remember that this affects the liver further. So your kidney injury affects the liver further. So when liver and kidney fail, the micronutrient intake is tailored to suit the liver failure. Some of the very crude and less scientific thoughts. And when macronutrient and fluids stage, you have to think about the kidney, not the liver. And the comprehensive nutritional management, there is a dietary and non-dietary component. So as all the speakers told, you don't need too much protein restriction even in tube feed, and you need a lot of physical activity to digest that tube feed altogether. And thank you very much for the kind attention. I'll stop here.
Thank you, sir. Very nice explanation. And usually, how to choose, sir, whether nasogastric or jejunostomy, on what basis we have to choose the feeding tube, type of feeding tube?
So the best tube is the nasojejunal tube, because it ensures a straight delivery to the jejunum. It's a controlled feed, and it avoids surgery. It can be placed radiologically as well as endoscopically. So think of that first. But the problem is, if you keep a nasojejunal tube beyond 6 weeks to 8 weeks, it will have a lot of mobility issues to the patient. So that is the reason why. So you start thinking of your first choice, then you find indications for the other choices like PEG tube and other things. So I know that a lot of literature in nephrology literature, PEG tube is much better. But in what we learn from oncology practices, we keep even nasogenyl tube for 3 months to even 4 to 5 months. And these patients are well adjusted and very well adjusted.
One more, sir. I think you are expert in artificial intelligence. So can we use this one to select the patient and which is risk for complications in selecting the patient? Can we use artificial intelligence?
So you don't need machine learning or deep learning. This algorithm creation probably what you are trying to make it. There are a lot of apps also available. You put the data and it will select the choices what you need. So it's a very superficial level of AI. But we also use sometimes on bedside AI-based selection of feeding methods as well. In the IAP in India Association, we use that very often. I am part of the association for selecting the dietary recommendations. Yeah.
Thank you, sir, for that crisp talk, sir. This is not a question. This is just a comment that as nephrologists, like when we actually encounter patients in ICU on tube feeds, RT feeds or NG tube feeds, like, we leave everything to the nutritionist or dietitians. They actually prescribe like what powder, what feeds have to be given via the tubes. So it's very important that we should get ourselves involved in that, like what we'll have to write the prescription, how much of protein we have to give, how much of energy needs to be given to that particular patient. So especially renal nutritionists have to be given a lot of importance here because they are the ones who know the patient's status actually.
And majority of the thing, this morely in the AKE settings, it is very difficult to manage because majority of the CKD patients already on dialysis. We have no much issues. Majority in the ICU with critical illness like acute pancreatitis and this hepatorenal syndromes is the issue for a prolonged. They require high calories and more protein. So to prolong the feeding through the nasogastric tube and the feedings what we are giving might cause electrolyte imbalances, mainly the hypernatremia, hyperkalemia. So we have to take care of what Kiran sir told, like what is the formula feeding they are giving, how much phosphorus, how much potassium, and the sodium, and the fluid restriction is very important in the AK setting, sir. Apart from the route of administration through nasogastric versus nasojejunal or gastrostomy or jejunostomy system, as well as routinely we will give a gravity-based system in the ICUs rather than a pump-based system where the volume will not be under control to the intensivist or the nephrologist. So the pump-based system might be better to have a control on the volume, particularly in the ICU settings.
The problem is something like this. How often you see a pump or nutritional bag in a dialysis unit? Less often, am I correct? So in your group of patients, we have to introduce a concept called catch-up nutrition. Catch-up nutrition is what you left behind on the previous day because of the long dialysis session or therapeutic schedule. So for your patients, a vast majority, 24-hour recommendations will not work because they are already caught up with investigations of dialysis at least 4 to 6 hours in a day. So other group of patients, we strongly advocate catch-up nutrition, what is left for the last 1 week and how this extra can be administered in the next coming week. So in a 24-hour recommendation, you may have to convert to a 16-hour or 14-hour recommendation without affecting the metabolic disturbance of the body. This is a very, very peculiar challenge, your specialty case. That's why we advocate catch-up nutrition. So your point is very good.
Thank you, sir.
Thank you very much.